Soundbytes. Quick clips, long-term learning.
So let's go through a couple cases here. The first one we have is an echo. Guy came in for chest pain. So what are we looking at here and how do we get this view?
Yeah, so this is our first view in the cardiac echo. This is the parasternal long view. So you're using the phased array probe. You have the probe indicator towards the patient's right shoulder, about nipple line, so fourth intercostal space, and you are just left to the sternum.
Perfect. Yep. And then let's point out some key anatomy that we're seeing here. So this chamber here outlined, what is this?
That's our left ventricle.
And then we have something moving here. It looks like a valve, and that's the
mitral valve.
Mitral. Up here we have?
That's the left atrium.
Left atrium. So what's coming through the left atrium through this mitral valve, and then ejecting through this valve here?
That's our aortic valve.
Aortic valve, right. And you have the left ventricular outflow tract going into the proximal aorta there. What about over here, the anterior portion?
Yeah, that's our right ventricle.
Right ventricle, good. So, and then deep to the heart, we have another structure here, circular, caught in transverse view here. What is this?
That is our descending aorta.
Good. So this sonographer did a good job of keeping the descending thoracic aorta in view while capturing the parasternal long, but why is that important?
By including the view of the descending aorta, you can kind of decipher between a pericardial effusion and a pleural effusion.
Yep.
Based on like the location of the fluid.
Right. So pericardial and pleural effusions can look similar, especially if they're out here, posterior to the heart around this 5 o'clock position. But a pleural effusion is going to go deep to the descending thoracic aorta, whereas a pericardial effusion will come here and split between the myocardium and this descending thoracic aorta here. So this is one structure that you want to keep in view. So when we're looking at a parasternal long axis view, one of the things that we can look at is kind of the gross estimate of the ejection fraction. So what do you think about this patient's ejection fraction?
Yeah, so I think it's moderately reduced. I'm looking at the anterior leaflet of the mitral valve, and I notice how it's not fully extending to touch the LV wall. So I would say moderately reduced. The squeeze looks mediocre.
Okay, great. So you mentioned the mitral valve, so let's talk about that a little bit more. So here they're doing a technique that's called EPSS, which is basically a way that you can quantify the movement of that anterior leaflet of the mitral valve. So the mitral valve has these 2 leaflets here, one anterior and one sort of more posterior. You can't make out quite as well, but about right here. And you can put M mode on, and then put your M mode cursor over the distal end of the mitral valve, and then watch for the motion of that mitral valve, and you'll create this graph here that we see below. So this M mode graph shows movement against time. So the x-axis is time, and the y-axis is the movement along this line that you set and you can adjust. So we're here about halfway down, we see where the mitral valve is moving, and that corresponds to this line here.
Gotcha.
And we have 2 peaks, right? So the one is called the E wave, and the next is called the A wave. So we can use a measurement called, or a technique called the EPSS, which stands for E-point septal separation. So do you remember what a normal EPSS measurement is?
I think it was less than 7 millimeters.
Right. So if you're, like in a normal healthy heart, the mitral valve should basically be almost making contact with the septum, and sometimes you don't even need to do this if it's very clear that the mitral valve is hitting the septum each time. But if you take a measurement and it looks bigger there, you can quantify that. So less than 7 is normal. Between 7 and 14 millimeters is moderately reduced, and greater than 14 is severely reduced. So this patient is 15 millimeters, who put this into more probably the severely reduced ejection fraction category. All right, next we have this view. What are we seeing here, and how did they go from this parasternal long to this view?
Yeah, so this is our parasternal short view, the second view typically, and you actually keep the probe positioning. You just rotate it 90 degrees counterclockwise towards the patient's right hip.
Perfect. Yep. So now we're seeing the ventricles sort of side by side, right? And we're at the level we call the papillary muscles. So we sometimes describe this sign as like the dinosaurs fighting. You see these little things here that look like little T-Rex arms that are boxing each other. Those are the papillary muscles that are sticking off the side of the left ventricle. That's opposed to the peristernal short at the level of the mitral valve, which looks like the fish mouth. And then if you go up even higher, you can sometimes see the aortic valve, and they call that the Mercedes-Benz sign. So another way that you can estimate ejection fraction here that they didn't do in the study is with something called fractional shortening as well. So that's when you take the end diastolic volume of the left ventricle and the end systolic volume of the left ventricle, and then analyze the ratio between them and calculate essentially the percentage change to see how much volume change there is between those two phases of the cardiac cycle. So that's another way we can estimate EF. Do you see any obvious wall motion abnormalities in this?
I don't. I think the wall is equally squeezing inward.
Mm-hmm. Yeah, so what I typically do is kind of like just put my finger or cursor here right in the center and just look to see all the walls are sort of moving in more or less similarly to my finger or the cursor in the center of the screen. Sometimes if you have like an inferior wall STEMI, for instance, or some sort of other insult to the heart, you'll have a regional wall motion abnormality where part of the wall is not moving as much. But right here we just have mostly like global hypokinesis. So where's the RV in this situation?
Yeah, so the RV is more to like the left of the screen, kind of the crescent-shaped ventricle.
Right. So this is the RV here. It's not super well seen in this picture, but it has that crescent moon-shaped here hugging the left ventricle. And we don't see any of the other findings. Sometimes we see like the D sign where the septum gets flat here because of increased right heart pressure. So now we have the apical 4 view. So how do we obtain an apical 4?
Yeah, so a different view, you're going to take the probe, and it's different for every person, but usually it's more lateral. It ranges between like midclavicular and midaxillary, and you're trying to point it up towards the heart at the apex, so around the point of maximal impulse, maybe 5th or 6th intercostal space.
Mm-hmm. Good. Yeah, so it's a little bit variable in each person, just based on sometimes the size of the heart, if they have dilated cardiomyopathy or CHF for whatever reason. But this is a good example of an apical 4 because we see the ventricles are aligned basically right on top of the atrium. So we have the left side of the heart here, the left ventricle, left atrium here, and then the right ventricle and right atrium here. We can see pretty clearly the mitral valve here and the tricuspid valve. You can actually see a little bit of the chordae tendineae and the papillary muscles here in sort of a longitudinal view. So the best view of an apical 4 is to have the interventricular septum in the middle, basically straight up and down. And the ventricles aren't foreshortened, meaning that they're look smaller than they usually are. So getting a good apical 4 is to get the ventricles as long as possible with the atria stacked on top or underneath like this. So what can you tell us about like the chamber size, the relationships between the LV and the RV, like what's normal, what would be abnormal?
Yeah, so I believe normally the RV is about 2/3 the size of the LV. Any increase in that ratio would indicate maybe potential right heart strain, either acute or chronic. And as I'm looking at the ventricle size, I don't see that the right heart is enlarged. It looks about appropriate, so I don't see any signs of right heart strain.
Yeah, perfect. Yeah, when that ratio approaches 1-to-1, you get more worried about right heart strain. And like you said, it could be chronic from pulmonary hypertension or chronic PE, but that is an abnormal ratio. So right now they're trying to show something called TAPSE. You remember what TAPSE stands for?
Yes, we just talked about it. It's tricuspid annular plane systolic excursion.
Good. So that is another technique where we're using M mode, but instead of looking at the valve, the tricuspid valve, we're looking at what's called the tricuspid annulus, which is a soft tissue around the valve, and it's on this lateral free wall. So they have the cursor over the lateral free wall of the RV, and you're measuring the up and down movement of the RV in that area with M mode. So you'll get a graph like this when you put the M mode cursor over this area, where you can measure the distance between a peak and a valley, and you'll get a measurement. In this case, it's 23. So what does 23 mean?
23, I think, is normal, right? Because we want above 16?
Yeah.
Okay.
Yeah, so above 16 is normal. That means that the heart is, moving well, or the right heart is moving well. But when you have right heart strain or RV hypokinesis, sometimes you're not going to have that up and down movement in that area. So your measurement is going to be lower than usually 16 or 17. What's this last view that we're looking at?
Yeah, so this is the subxiphoid view that you get with aiming the probe directly under the xiphoid process, essentially. So almost parallel to the bed, very, very flat with the patient supine.
Yep, good. So sometimes people struggle with getting a good subxiphoid view like this. What are some tips that you can use to get a better view if you're struggling?
So you can have the patient take a deep breath, and another thing you can do is you can kind of use the liver as an acoustic window because the waves travel pretty smoothly through the liver. So you can kind of go a little bit more right, but then still aiming towards the heart.
Right. Yeah, I think that positioning really helps, just having them lay down flat. Taking a deep breath in is going to contract the diaphragm down. The heart's basically sitting on top of the diaphragm, and then it will move down towards your probe with it, more towards the abdominal cavity, and get you in better view. With echocardiogram in general, you can get better views if you actually turn the patient to the left side as well. So that'll bring the heart forward along the chest, and will help you get a little bit better views. Is even on your like apical 4, just like rolling them to the side. It's really helpful.
Soundbytes. Quick clips, long-term learning. This soundbite is a shorter, digestible segment taken from our monthly Soundcheck podcast. For the full episode, check out the podcast on YouTube at youtube.com/MedStar Emergency Physicians or visit mepsono.com.